Dziękuję za miłe zaproszenie na konferencję. To dopiero moja trzecia wizyta w Polsce i jest bardzo żywotna. So, just to say thank you for inviting Keele to come to the conference, and we will take you through a journey of our work in our unit. Keele is in the heart of the UK, and it's, as a university, one of the largest campus-based universities. It has 600 acres of land. We have a school of medicine, a school of physiotherapy, nursing and pharmacy. But I do know for most of you are just wondering why an English professor has such a Polish-sounding name and such a particular Polish name. So I can explain. So my father, born in 1913 in Poland, he was in the Polish cavalry at the outbreak of World War II, became an early prisoner of war, but did make it to England and joined the Polish army there. He met, after the war, an English woman and married her. And had a little girl he called Krysia. And he adopted an English name. But of course, after my father passed away and when I was old enough to make my own decisions, I took my passport and my documents and I reclaimed my Polish name, Krysia Dziedzic. And of course, my father never told me because I was always his Krysia, but at some point I needed to become Christina. So I'm Krysia to my colleagues. So I have to say, Matthias, our parents have got a lot to answer for. So this presentation will explore the evidence to practice gap for upper limb pain with some examples and describe the role of knowledge brokering, as we're calling it in the UK, an ongoing implementation of best care. So I'm hopefully taking you through a presentation of describing evidence on one side, impact on the other side, and the transition between one to the next as we go. And it's obviously not very linear. It doesn't have to be in sequence. It can be quite messy and complicated, but this is some of the thinking. So you'll be very familiar with Global Burden of Disease project data. We have them for all our countries. We can explore that. These are data that are quite old now, 2010 UK data. But the pattern is very familiar. If you look at the lilac bar, this is joint pain, musculoskeletal joint pain. The other large area is mental health, and that is green. Now, if you dropped a line down and took everybody 45 years and under, predominantly you would be looking at low back pain in that group. And if you take the line from 45 years and over, you're looking at osteoarthritis. Musculoskeletal pain is predominantly managed in primary care, certainly in the UK. So a lot of what I'm talking about and a lot of what we'll be sharing with you will be our experiences as part of a primary care centre of excellence of research. So in our epidemiology data, our clinical epidemiology data, we're also very interested in this symptomatic osteoarthritis. And we follow NICE recommendations. So the recommendations that have been recently updated in November this year that describe osteoarthritis in people who are 45 and over, have activity-related joint pain, have no morning stiffness that's lasting more than 30 minutes. And this can be then ascribed to osteoarthritis. And in the latest NICE guideline, they will say you can make that diagnosis in primary care without an X-ray. And that's now a recommendation in UK practice. In our own research in epidemiology, we did some large clinical assessment studies of the hand, knee and foot. And when we looked across all the data, we actually determined that it was hand osteoarthritis that was the most prevalent type of osteoarthritis in primary care and the community. So the hand was more prevalent than the knee, and the foot. Now, the high prevalence was due to the nodal interphalangeal joints, particularly in women, very high prevalence, and thumb osteoarthritis was the most frequent subtype, with nodal osteoarthritis also common. But osteoarthritis isn't just defined by a kind of a biomedical model. It can also be defined as the illness and the experience of the individual. And these are a couple of quotes from an individual, again in our research. Everyday things that I take for granted, things like opening packets, cutting meat, even with an electric knife, just gripping the knife itself. So these everyday tasks people are saying they're really challenged with. But it's not just the physical functioning, but it's also how people feel as an individual. And one person said, you feel diminished as a person living with this condition. So it's very important that when we're considering joint pain, it is a very complex, multidimensional approach that we're thinking of. So where might we find best practice? And if we come to Europe, we'd be looking at the EULAR recommendations for the management of hand osteoarthritis. So the recommendations, as you will expect, have core principles about best practice, so treatment goals, providing information, having individualised treatment, sharing the decision-making around treatment, and it's multidisciplinary. Also, the importance of non-pharmacological treatment, education, assisted devices, exercises, and pharmacological treatments, predominantly using the topical treatments first over other oral pain relief, and then considerations for surgery and follow-up. So one of our clinical trials has found its way into the guidelines and most recently into the NICE guidelines. So this is a trial that we did with people from the community who were defined as having hand osteoarthritis, and the intervention itself was delivered by occupational therapists, but physiotherapists could do similar approaches. And the two very key treatments were the joint education approaches and hand exercises, and very much the cornerstone of treatments. So the joint education involved classes, people coming in groups, having group sessions with the therapist and rehearsing ways in which they would use devices, the way they might prepare a meal, all of the activities to reduce the strain on joints and to use gadgets and other ways of doing things to reduce symptoms. And then a program of hand exercises, again in a group approach. Now, we recruited from the population, so we sent out a survey to 12,000 or more people who were registered with the general practice, and they were 50 years and over. In the survey, we asked them questions that we'd previously researched in our clinical epidemiology studies. So we knew who we could invite to a clinical assessment who was likely to have osteoarthritis on a clinical grounds. And out of those people who were recruited and consented to be in the study, we randomised them to 4 treatments. But the approach that we took was actually to ask 2 questions. So for those trial methodologists in the audience, this was a factorial design. So we randomly allocated people to 4 different treatments, but we analysed them in pairs of treatments. So we asked, is joint education more effective in reducing hand pain and disability than no joint education? And then are hand exercises more effective in reducing hand pain and disability than no hand exercises? So the cells were combined in those analyses, and we did both clinical and cost effectiveness analyses. So we used what we would know as the Aussie-OMERACT responder criteria. So that is defining a person who had responded to treatment. And at our primary endpoint at 6 months, the important thing was to note, if you received the joint protection, the joint education approaches, you were twice as likely to be a responder to treatment than if you hadn't. And it was the only point at which there was any statistically significant difference in the treatment approach. For the joint education, we also found that arthritis pain self-efficacy was, again, statistically significantly beneficial at every time point we assessed. So this was asking people how confident they felt in managing their hand pain. And their confidence grew having had the occupational therapy classes for the joint education approaches. Hand exercises, very interesting. So we didn't find any clinical effectiveness of the hand exercises. However, over 12 months, the hand exercises were found to be cost effective. So in measuring cost effectiveness, we use quality of life. So rather than measuring the responder criteria and pain and function and overall improvement, we're actually assessing quality of life. And over 12 months, the cost effectiveness was in favour of the hand exercises. So good news for therapists. You have choices in treatments you can offer to patients. And if you're seeing the patient, you have the option of offering them the joint education approaches and the hand exercises. So with all the evidence that we have from clinical guidelines, from original research, what do we now do with that to create an impact on the individual, on the service, and on the population at large? Well, what's happening between, and what is the treatment gap? So, and we know we have hand surgeons in the room, and we know from a study in Norway to actually look at the gap in non-pharmacological treatment prior to surgery, and this is very similar in the UK. Only 21% reported having received the non-pharmacological treatment before referral for surgery. And that's not an unfamiliar something that happens in the UK as well, and it's not just for hand osteoarthritis, that will be for lower limb osteoarthritis too. Most patients reported actually no pain or mild pain when they were on the list for surgery, but thumb OA was negatively affecting all aspects of their function, so that was important. So if we also go back to the patient and ask them, what is your experience of the treatment offered to you? So this person said, I went to the general practitioner, nothing we can do about it, he said at the time, and I got really bad pain, which is why I went. Down the thumb, I honestly wouldn't ever go back and waste their time, because he said there was nothing they could do. Now, let's not just blame the GP. So we've got physiotherapists. They've been giving me my exercises for my neck, but they've never mentioned about my hands at all. And I've said I've got arthritis in them, but they've never offered any help for them. So that's for my neck, my shoulder, and everything else, but not my hands. I mean, perhaps it isn't bad enough, I don't know, but by gum, it's painful, you know. So again, that even where we have evidence of some therapies that could give some benefit to people with hand pain and functional limitations, that's not reaching the patient in the consultation. So what are we going to do about this evidence to practice gap? So something that we've been adopting that's been very active in Canada for many years, but is now gaining a lot of traction in the UK, is this concept of knowledge mobilisation. So how do we take and mobilise knowledge from one place to another, recognising that doing the research on its own is not enough, because that's not going to change what needs to happen. Knowledge mobilisation can be defined as sharing knowledge between different communities to catalyse change, and it's actively taking knowledge where it is needed. Now, there are some ingredients that make it really helpful and make it very active. Having knowledge mobilisers, so there are people who have networks. They develop the patient voice and they host evidence-based practice meetings. So that's a great way of mobilising knowledge. And here today we are, and we have become, those of us new to this group, part of your community of practice. So a community of practice is a group of people who share a concern, a set of problems, and are passionate about a topic, and who deepen their knowledge and expertise by interacting on an ongoing basis. And you're doing this every year where you can, to interact on an ongoing basis, to share your knowledge and share the learning. So you have a shared interest, you have joint activities and discussions, learning takes place, you build relationships, and you have the repertoire of resources and practice that you can share across the conversation. You'll hear more from colleagues on our patient and public involvement and engagement, and that's a very key pathway to impact. So if we have the option to mobilise knowledge, what is impact? In the UK, all of our academic achievements are assessed every 7 years according to the Research Excellence Framework. And increasingly, the government is making impact a more important part of that system. So that's any effect, change or benefit, something that's tangible, that's different, that you can really see. And it can be to many things: the economy, culture, public policy and services, health, environment, quality of life. It's very broad ranging. So in order to distill the research into something that you can then mobilise with people, you need something. So you may need innovations, and you may need innovations that are a new model of care, so a new service that you develop and you deliver in a system because it embodies all of the evidence that you want captured. It may be patient information, and we have an osteoarthritis guidebook. If you Google Keele Osteoarthritis Guidebook, you have that. It's written by patients and health professionals for patients. It has been translated in other languages as well, into Dutch, Norwegian, and now in Maori in New Zealand, so lots of different languages. And one of the other innovations we used in general practice was an electronic template in the medical records. So when the practitioners recorded diagnoses of some form that might be osteoarthritis, a joint pain of some form, then the template triggered and reminded the GP or the nurse to have a conversation about joint pain. And in this graph, you can see to the left of the graph was the period of time of 1 year prior to us putting the template in. And then the horizontal bar is when the template went into 8 general practices, and the time after we put that template, that prompt in. And the one thing that you can see in the medication is the green bar shows that the topical anti-inflammatory medication was offered increasingly more after the template went in. So just a prompt to remind people to think allowed that treatment to be offered as part of the consultation. And what did the health professionals find? So we took this model of care because it didn't change their non-pharmacological approach, and we upskilled GPs and nurses. And how did they find it? So they found, first of all, it made you try and take a more positive approach rather than just saying, well, you've got arthritis. And I think it also gives you a few more strings to your bow in terms of what you can tell a patient, what you can inform them, and what we'd be able to offer. And practice nurses who have not traditionally been trained in musculoskeletal health talked about a consultation, a patient saying, she asked me about the nodes on her hand, and it was, the shape of her hand and arthritic pain, and you could see it was arthritis. So I was able to give her a bit, tell her a bit about it, and even give her a couple of exercises to do. So people live with their condition throughout their lives, and they consult multiple different health professionals. So it's really fortunate if we can get multiple health professionals to all have the conversation about something can be done, and these are the things and the options. So we've seen that we can take evidence, we want to make an impact with the evidence, and there is this transformation of evidence through innovation, through knowledge mobilisation to get there. So hopefully the presentation has explored the evidence to practice gap with an example for upper limb pain, and described the role of knowledge brokering in the ongoing implementation of best care. And of course, we never stop where we are. And you'll hear from Anna about her experiences of some new research that we're working with Leeds University and others called a digital My Arm Pain app. And the plan now is to build from the start of the research study the process for accelerating the uptake of the knowledge at the end. So you don't wait until you have your trial, then your guideline, and then what you might do in practice. That when you finish your research, you've got something that can be used straight away in practice. So we'll keep you posted on that, and hopefully we can come back and tell you how that's going. So I'd like to acknowledge all the funders that have enabled this work, and to thank you for your attention for this first presentation. Thank you very much.